We're live on YouTube. Just connecting on Instagram. Yeah. Okay. I believe we're live on both the platforms, so we can start. Uh, Good evening to everyone who's tuning in. Today's theme of discussion is treating chronic pain as invisible disability. Allow me to introduce our speakers for the evening today. Dr. Shobha Ranganathan is Associate Professor, Department of Liberal Arts, Indian Institute of Technology, Hyderabad. Her research draws on range of disciplines such as anthropology, gender studies, disability studies, and alternate paradigms within psychology, such as critical and qualitative psychology. A very warm welcome to you, ma'am.
Thanks. Thanks very much.
Um, we are also joined by S. Mahalakshmi, who's a PhD scholar at Indian Institute of Technology, Hyderabad. Her work and interests lie in the intersection of care, chronic pain, and mental health. A very warm welcome to you, Mahalakshmi.
Glad to be here.
So, to begin the conversation, could you perhaps explain what the term chronic pain entails and the context of your study and the interlinkages that you see between chronic pain, illness, and disability?
Sure, thank you. So, the biomedical definition of chronic pain in simple words is pain that is more than 3 months. That is the most basic definition, but of course, it is not as simple as that because people suffer from it for decades, as can be seen, and sometimes medication is not working, and there is a constant search for relief.
Yeah.
So, in fact, ICD 11, they have only in 2019 have updated to include chronic pain as
Mhm.
a health condition by itself. So we can see how recent these turn of events are. So it is considered as a health condition of its own and as a secondary symptom that could coexist without being because of other health issues. So only in 2019, that is ICD has incorporated in 2019 and published in 2022.
Right.
So it's not even like 5 years old. So we can see how recent, and also it reflects the increase in chronic pain across the world. It talks to how biomedicine or the categories are not broad enough in ICD-10 that they have brought about this change, and how patients have been suffering for a long without relief or a diagnosis. So it brings about talks a lot to all these. So this that is why I also wanted to work in this area to understand,
Sure.
especially in the context of India.
Mhm.
Yeah.
Yeah. Very well said. Thank you for laying out the context for us. In your EPW article, you also mentioned the work of scholars like Dr. Machi, 2017, who have focused their attention on not on specific biomedical categories or diagnosis, but rather on experiential categories. What is exactly the disability centered approach, and how does it integrate the experiential realities of pain, and what are its ramifications for society?
Yeah, so I can take that one if that's okay. Um, so to answer the second part of the question about what is the disability centered approach, I think basically what we
Mhm.
want to highlight when taking a disability centered approach is that the role of the environment, the structural factors, and the systemic factors also, which result in disabling experiences for people. So
Right.
conventionally, when one thinks of chronic pain, like Mahalakshmi just said, one thinks of it as a symptom of a disease or something else, but we need to see it as a phenomenon in its own right.
Hmm.
Um, Pain can also, be so extreme that it can actually be disabling, right?
Yes.
And in that sense, we want to sort of, it's not so much of, what is the label as such, whether, what kind of disease or what kind of illness that we are focusing on, but what is the impact of that on an individual, and that is where
Absolutely.
the experiential part becomes important.
Absolutely. Um, could you share some insights from the three case studies from your research based on a pain clinic in the city of Hyderabad and their implications on the broader understanding of the narratives around pain?
Sure. See, and also just adding on to Shubha ma'am's talk on why disability is, one thing that is also I'm seeing is when it is not, especially, when it does not fit into some of the categories. It,
Hmm.
yes, sometimes, yes, they do not, we find that the necessary diagnostics is not recommended in a couple of years. It takes, they take some time before, but even after years, or when they find that nothing is showing up in diagnostics, what happens is psychology is like the last ditch. Okay, so
Hmm.
this is not a physical pain anymore. This
Sure.
is there's something wrong with it's not even, again, the blame is placed on the patient, saying there's something wrong with your mind, you're too stressed out.
Hmm. Right.
It's psychology, or the mental issues is not given the importance. It said, okay, in the end, it's you, maybe you have to strengthen yourself.
Right.
So that placing more onus on the patients, it's actually when they are already dealing with pain. When
Hmm.
I look at my data, I see that on a pain scale of how long, how much has your pain been, the average that people say is it's 7 or 8. 7 or 8, or 0 to 10 is not lower, it's not less. And to say, and again we blame that it's because of you, or maybe you need to distract yourself, go out, do this, do that. It's again, you're not validating what the patient is saying.
Sure.
Yeah.
And
So yeah.
yeah, just to add to that, do you think it also delays the diagnosis significantly and that can have repercussions of its own?
Yes. So initially, what happens is whenever they go, okay, fine, you're given a painkiller, something short term, a short stop. Okay, let's see if it works. But what happens is it's years and still that short stop is only used.
Hmm.
It's years and years are going, still only painkiller is given. And
Hmm.
sometimes in one of my, which I'll also talk about, they were allergic to painkillers, and hence they had to stop using that. So, and but there was nothing to substitute it.
Hmm.
So just be with the pain, and hoping that as time goes it will reduce. That's
Hmm.
what happens. Maybe it does at that time, but it comes back chronic. Sorry, it comes back next year or a few months later. So that is the thing with chronic pain. It's also like it's constant in the sense that the same 7 or 8 is there throughout. It comes, it goes off, and after a couple of months it comes back. Maybe the intensity is severe or lower, but there is always that fear of when is it going to come back, because I am not completely cured.
Hmm. Right.
Yeah.
Absolutely. I feel the alternatives might also start emerging once like you mentioned, the recognition aspect and the acceptance aspect becomes more common in society.
Yeah. Right.
So,
And yeah, so you also asked about some of the insights from the case study.
yes,
Yes,
yes.
right. So the three participants that I have focused on mainly are one is Gangama.
Hmm.
So to talk more about her, and I think it's good to mention that all the names have been changed for confidentiality purposes.
Right.
So Gangama, she is actually quite interesting to know that I met her in a pain clinic in one of the very elite areas of Hyderabad,
Okay.
where treatment is not cheap at all. But she comes from she a fisherman's family, like her husband is a fisherman. So we can, gather that she is from a low socioeconomic criteria, but she has moved from her town to city to stay with her daughter and her family, married daughter, because she's not able to bend anymore. She's a homemaker, which means she's not able to carry out her home duties, and she's not able to bend or wash clothes or whatever. So she has moved to the city of Hyderabad for seeking relief, pain relief, as
Mm.
well as a support, which shows that usually chronic pain is sometimes considered as the affliction of the rich, affliction of people from, because you're sitting all day. That is why you get lower back pain, knee pain, because you're not working out, you're not exercising, all that. But that is not the case anymore. So we need to be aware of that too. So I found the three narratives that I've chosen for the article are unique in the sense it brings out their trauma, but also is reflective of the other narratives that I have conducted as part of my research. So
Absolutely.
going ahead, next would be, let me first talk about Manita. So again, she is a homemaker, but she is more, in the middle economic strata. But she is also a homemaker who's been cooking and cleaning all everything for her family for a long time, whatever the needs that are placed. In fact, she says. Her pain level was around 10 when I asked what is your pain level. So, and it's only after 15 years they even bought a washing machine, because your your work is not like, important, or it's not painful enough anyway, it's work. So even though they might or may not have been, but it took them 15 years for the family and the doctors. This is where I was talking about how for a decade, only 6 months before my interview was she even asked to take an MRI. Before that, they were advised to take X-ray. They did take an X-ray, and she was accompanied by her daughter. And her daughter said we would take her to multiple doctors, but all the doctors would say everything is fine. There is nothing wrong with her. I just would give painkiller, but painkiller was not enough because the pain was come, and if she was allergic to painkillers, right? And
Right.
last is Sarita, who is quite interesting because she's a working woman. She works in a government school, which means
Okay.
that she didn't want to quit her job. And she has to travel nearly 30 kilometers to school, so which is around 60 kilometers up and down. But her pain is such that she can't even go. It is difficult for her to take an auto from front of her house, but she has to travel by bus. Being a teacher, she has to stand almost through the day, because especially to students, it's frowned down upon that they are sitting and taking and everything. So the doctor said, "Let's wait for your retirement, post which we will do surgery." However,
Okay.
there was still another good 4 5 years for her retirement, and so she had to bear that pain. So she would wear knee pads, or take maybe sit for some time, and she was recommended maybe exercises, physiotherapy exercises, but there was no time between the traveling and the work and coming back and taking care. So also, especially these collecting these become important because it also brings about the mental health of these patients. So one thing that was coming up strongly was the mental health narrative. Patients saying sometimes it was just unbearable that they felt they couldn't carry on with their lives. So these are all becoming. They all showed up in my data.
Absolutely. And I think this aspect also draws us to a point Dr. Shobha made about this distinction between merely diagnosing someone and labeling them as a biomedical category versus actually understanding their spectrum of experiences through a experiential category. Um, do you think that the experiences of patients can improve the medical management of pain?
Yeah, definitely. Just as I was saying, these narratives brings into focus the psychological issues, and this is not just for women. Both men and women have the mental health is affected. Actually, I've had my participants who were accompanied by their family said, even for a man, that their behavior and their personality was changing. who was once a person who was calm, collected, who was, going out swimming, who was enjoying his life, who would do work around the house by himself, is now just focused, or, is bounded to a chair, getting quickly irritated, losing his temper, because they don't know how to deal with chronic pain. These people also have to fight the system, because being attached to any particular government job, they have certain things through which only they can go. So doctors again don't take their pain seriously and just write off as, just painkillers, again and again painkillers for a long time before they, are taken seriously.
Right.
So both men and women have reported how it was affecting their mental health, and how they are not able to continue because it was so bad. So it was, I mean, it was me as a researcher, it was quite interesting, because here I am as a 26-year-old researcher meeting this person who was 40 plus, but they were willing to open up to me, which
Absolutely.
they, telling that I just can't do this anymore. But they were, and also I asked, do you talk about this to anyone? They say, I can't talk about this to anyone much, because it is my pain, especially men. I can't talk, we talk about men and their mental health. They say, I might, I only tell my our partners, only they might know a little bit of pain. Otherwise,
Okay.
I think that, my other family members might see how much I'm suffering with the way I'm behaving, because I'm not able to bend as much, or move as much. So they do not also vocalize, especially in their workplace, because they feel at their workplace they're not going to be taken seriously.
Absolutely.
These are all, and also when, these things do not come when they go to the doctor, because there is just not enough time, because already the waiting list is too long. There are a lot of patients waiting
Yeah.
to meet the doctor, so there is not enough time. So when they go and meet the doctor, it's all about how are you, how is your pain, where is it paining, what are the treatment options.
Right. Right. Which also brings me to my next question, where in your article you also talk about the categorical and diagnostic difficulty in the validation of pain. For like you have argued, pain is not visible or measurable. Why is this a grave concern for medical diagnosis? And alternatively, how would it help to see chronic pain through the lens of disability?
Yeah, so maybe I can respond to this one. I think
Sure.
the core of what we were trying to argue was that chronic pain is not just a medical phenomenon. Okay, it is not just a disease. It is very much of related to social, cultural, political, economic factors as well. And you cannot really engage adequately with pain if you're not engaging with those, right?
Yes, absolutely.
So um, so pain is also related to people's everyday routines. It is also related to their workload, right? It's also the kind of back-breaking work that they might be involved in. So it's connected with labor as well, right? um, so in that sense, it becomes important to also and this is not a kind of disease which can be sort of visibly seen on any always seen on a scan or tapped into any kind of any may not emerge on any test or any investigation. You may not be able to get a number for it, and so therefore the experience of the patient herself, the narrative, that becomes really most important, right?
Right.
The clinical encounter becomes the most important sort of yardstick. But unfortunately, medicine also over the years has become increasingly sort of distant from that clinical encounter. It has become,
Right.
it has relied excessively on, the visual, through investigations. It has tried to, reduce diagnosis to a question of metrics, right? But diagnostics is also about dialogue. It's also about conversation and listening to the patient. um,
Yes.
and because pain is not always, visible or doesn't necessarily have a specific, cause that it can be clearly linked with.
Yeah,
Patients struggle incredibly with, invalidation, with being told that it's all in their head, doing, told that it's all related to their anxiety and their stress, right?
hmm,
It becomes individualized in that person's,
absolutely,
mind. Whereas it's also, it's also structural. It's also systemic, and that is
absolutely.
where, taking a more contextual perspective
Mhm.
is something which is important.
Yes, definitely. Um, you also underscore the need to politicize pain, and specifically, you cover the incidence of denial of women patients' pain as well, which, as your research indicates, has often led to diagnostic delays, inadequate access to care, among other challenges. Could you elaborate on how the politicization of pain could help bring these challenges to light?
Sure. Yeah, see, the pain is being is taken years, if not decades, to be taken seriously.
Hmm.
The way in which the pain and its care is met out is also different. So, especially in my research, most of them are middle to elderly aged, and significant ratio of them are homemakers.
Right.
Right? So the pain is not given that credibility. Anyway, you're at home. Anyway, you're taking care of home, work in the home. You have this time and the space to rest. But that is not the case. There is something one after the other that is coming up. So what happens? Is that so what happens is that there is no leeway for them, in the sense, because they are already at home working. There is no leeway for them to ask this. For example, the men that I interviewed, they say yes, their workplaces, bad working conditions, the employers are not listening, or there's no space for them to even talk about the pain. For example, even asking for an ergonomic chair
Right.
in an IT company, there is no space or provision or any people sponsoring or funding for them to get a chair. That is not there. Yes. So even though that is there, when they come home, they get to rest. They get to lie down. They get to do work such as read newspaper, watch television, and take that break.
Yes.
However, for women, especially homemakers, they are already at home. There is not that line that is dividing them or saying, "Okay, I'm at home. My home housework is done. Now I can take that rest." That is not there, right? So, and second is, since most of them are with higher socioeconomic status, what happens is, yes, they are able to afford a maid. A maid becomes a huge source of a house help, becomes a huge source of support for them. They
Right.
do come, they do in half an hour do all the cleaning and things like that. However, still there is the rest of the housework that still falls on the women. I mean, this is just something that I thought quite interesting that I wanted to share. So
Mhm.
there were elder aged, a man and a woman who I interviewed, both of them within the age range of 75 to 80. In fact, the lady came to the hospital in a car, in an automatic car, because she felt automatic cars were a blessing because it was easy on her knees. So
Okay.
the guy, he was also 80, retired and everything. So why did they come to the pain clinic is, the gentleman came because he wanted to have more time to engage in his hobbies such as reading and painting. However, the women who came in a car, she does have house help. Still, she spends an hour and a half cooking. So I want pain relief only so I can engage in that cooking.
Hmm.
So those responsibilities still do lie with the women, and what is the reason for the pain relief is also so different between people. So, and also we also need to talk about this and organization, because even though they want that break, for example, men, they want to leave the job or take a VRS, that is voluntary retirement, or they want to cut down because the pain is just unbearable. that is not being granted to them in for men. For women, what happens is, so if there are three things. One, like Sarita, if she has to go for the job, it's a salaried job. They have to end up going because it's a source of income.
Mm-hmm.
Okay, what if the woman is having her own business? They had like tailoring business, some other kind of business. So what happens is, if they had 10 people working under them, they would bring down them to one or two because it is restricted. In worst case scenarios, they come with the job. So we can see that okay, there is someone to support them, fine. But if they are in, a single, if they are living by themselves or they have to be the breadwinners, we can
Mm-hmm.
see how the job does not provide. The chronic pain takes away a bit of their identity. So it becomes very essential to talk, have a dialogue with our policies, with our laws, and see how much more they can accommodate. In
Right.
fact, the social media, whenever I come across chronic pain heroes, the one of the things is there work from home option available?
Mm-hmm.
Is there, because I have pain and I cannot tell the my employer that my pain is going to come today. But the employers need information like a week ago or whatever to tell I'm going to take off on this particular day. But I cannot tell when my body needs a rest or when I'm going to get a pain attack. I have no control over it. So, is there some kind of a work from home, a flexible job that I can do so that I can support myself? So,
Certainly.
so this entire dialogue around that needs to, we really need to work that out because we unfortunately see a higher incidence of chronic pain, be it fibromyalgia or even be it lower back pain, or there are so many pain that they say it is paining, but it does not come in their diagnostics. So it does not come up. So what do we do then? But that does not mean we invalidate them saying, invalidate their talking about pain.
Right. Right. So, uh, how do factors such as burden of unpaid care responsibilities and economic constraints impact individuals dealing with chronic pain? Do you think a reformulation of the idea of chronic pain can help realize the perils of living a life with such pain and the depth of such concerns?
Yeah, sure. I think a couple of points we've already covered earlier also of
Sure.
how unpaid care responsibilities it becomes a point especially for women. So in fact, women, when they come to hospital and they say it is paining, they are mostly taken care of by their daughters. So in fact, they are happy or more. There's a relief when there is their daughters are on a holiday or a vacation because there's someone to do or help around the house, and they are like, I don't know what is going to happen when she goes off. It's so even if so that is something that comes up a lot. And like I said, with lower economic constraints, what happens is there is no option of hiring a house help anymore. So in that case, they just have to manage by themselves and sleep or take rest. So that is, in fact, what is happening is increasing the guilt they are already facing. It is increasing the guilt that I am not help them. I'm not able to help out my family, especially for women who are in a joint family. Like they have their grandkids, sons, daughter-in-laws, and husband. So they are like, I used to be able to do everything,
Sure.
right? And now I'm depending on someone else for this, and I'm not able to contribute, and someone also has to help me.
Mhm.
So there are all these that come up when in unpaid care. Usually, it is so daughters who are the first source of help. Of course, husbands, partners nowadays are also helping. However, we need to keep in mind these are intermittent. However,
Yes.
sometimes pain is not intermittent. Pain is chronic.
Hmm.
So what happens when it is years together is that they have to devise their own strategies to see how what they can help. That is why maybe getting a kneecap or, for example, one of my participants had said how the pain was there and her fingertips had become numb. Right. So now she was not able to lift a glass or whatever. So her friend suggested, why don't you keep a wallet and keep your teacup on top of it so that you're supporting. So they have to come up with these kind of short steps and see how they can be of help to themselves.
Very well said. Um,
I just wanted to add something which came to my mind,
yeah, sure.
and when we were talking about the politicization of, pain,
Yeah.
and also, treating chronic pain as invisible disability. So when you talk about a disability, right,
Hmm.
what is expected is that there will be accommodations, and I think that is what we are really sort of, saying there,
Yeah.
that accommodations are sort of important and required to
Hmm.
understand that uh, this is as disabling as what we
Yes,
conventionally think of as also disability, right? So,
absolutely.
I mean, right now, what is happening is largely it is individuals who devise, their own strategies, their own
Hmm.
hacks to sort of, get by. But apart
Hmm.
from that, from the organizations, from the institution,
Hmm.
from the institution of the family, right? There need to be like accommodations as well.
Absolutely. And I think there should be a mindset shift as well, accompanied by our for our understanding of the term accommodation itself. And rather than viewing it as a privilege, we ought to view it as a basic human guarantee and a basic necessity. Do you believe that drawing from different perspectives, adopting multidisciplinary approaches could contribute to a more robust framework for both diagnosing as well as treating chronic pain?
Definitely. In fact, published care for chronic pain. So it is, yeah, the medical professionals also, they are like overwhelmed with the amount of people like who come up, and so there is just not enough conversation that takes place. Conversation of not just how much it pains, but how, what are the other things that is affecting their is being affected on the everyday, which actually causes more pain. For
Hmm.
example, one of my participants, being a research student, she said of medication and whatever, her experience with it was such that now she was finding her speech slurring. She was finding the way in which she was interacting with people was different. So she felt this
Hmm.
loss of personality was more affecting her more than the pain itself.
Hmm.
That conversation does not happen with a biomedical profession. So there is a need for psychologists to be involved. There is a need for physiotherapists to be involved.
Hmm. Absolutely.
In fact, when the space that they need. However, it was found that doing these physiotherapy exercises and techniques done on a longer period of time was actually helping them. And they didn't need that surgery which was recommended first. They could first try out all these and then see. And they said, they reported that yes, I had to come weekly for so long, but it was definitely helping me. Right. So even nutritionists, dietitians are needed because all this pain, for example, be it be surgery for knee pain or be let it be in pain clinics, the platelet rich therapy, that is PRP treatment that was done, all of them seem to again place the blame on the patients when the treatment wasn't working, because first they had to lose their weight.
Hmm.
Enough exercise that was happening, because when their knees, for example, knee or leg is paining, when they exercise or even go out for a small walk, it was going to pain more. So they are again bound to a particular location, which meant that they were not taking care of their health as much as they would like to. And the doctor would say, yes, it is supposed to work, but it is not working because you haven't lost the weight. You have to take. How to do that? They are not given
Yeah.
information regarding that. So there is a need for dietitians to be part of the team. Care, that is biomedical plus physiotherapist and other allied psychologists, other allied health professionals to be part of the team becomes very essential.
Very well said. Dr. Shubha, would you like to add concluding remarks?
Um, no, I think you know we used to think of maybe all of these things, disease, maybe chronic illness, pain, disability as sort of separate kinds of categories, right?
Hmm.
But increasingly, what we're also seeing is that there are connections and there are linkages really
Hmm.
between them. And so for instance, a disability may be related to impairment, but it may also arise from chronically engaging with pain over time, for
Sure.
instance.
Sure.
So I think that, and that is where uh, we found it interesting to say that, okay, what will happen if we think about chronic pain as an invisible disability and not just as a symptom of a medical kind of phenomenon, because then that takes you to the root of what kinds of adjustments can be made in the environment, what accommodations are required, what rights need to be protected, like the right to be able to work from home, for instance, right?
Absolutely.
um, so that is really what we wanted to highlight.
Thank you. I think with that, we can call it a wrap to this particular session. I'd like to take a moment to thank our audience for patiently tuning in, and also, as a side note, to subscribe to us and follow us on our social media. The article that we discussed is available on the PW website for you to read. Um, at the same time, such conversations must keep on happening, because I think it's only the beginning. Once we enter into such conversations, will we even be able to understand how complex the challenges are that lie before us, and only extending institutional support, extending social support, extending familial support, um, can help break out of that individualized idea of pain and make it a bigger teamwork effort. Thank you once again to both of our speakers for giving us such enriching and invaluable insights. Uh, have a good
Thank you for
evening.
listening. It's been a pleasure.
Thank you for
Thank you.
having us.
Lovely having you both. Have a good evening.